Okay, welcome everyone to this interesting session to learn from innovative projects about empowering communities in TB service delivery at primary healthcare level. First up, we have Petra Heidkamp talking about the role of the community in the TB service delivery based on a literature review that was conducted to explore some of the existing models of care, including the community and various other providers, such as education and awareness on TB, TB screening, sputum collection, treatment follow-up, and contact tracing. I found it very interesting. I had a sneak preview, so I'm sure everyone will enjoy it. Thank you, Petra.
Well, thank you, and thank you all for being here. Before I start with the presentation, I just wanted to let you know that we're now starting track 4. And as track 4 lead, I feel that I should welcome anyone for the next 6 sessions are all on track 4. They're all on access to new tools and technologies. And the presentation or this session is actually looking at the community mechanism, the community systems that can adopt new tools and technologies. And we know that often the new tools and technologies do not reach communities or those health providers. And so we wanted to highlight this. The next 5 sessions of this track will all be about the new tools and how communities can be involved in the clinical trials or in the research, but we wanted to focus on the community systems. So that's what I'm trying to do today. Let me see if I can get this started. So I have no conflict of interest to declare. And my presentation is setting the scene for a few of the wonderful examples that we know are happening around the world in empowering communities in TB service delivery at the primary care level. And so we would like to share some of those experiences from the innovative projects. I work at the TB PPM Learning Network, and the work that we're trying to do is actually share experiences, peer-to-peer experience from those many community and private provider examples. We're focusing very much on private primary care providers, but that is also closely collaborating with communities, as you will see. And I wanted to start this slide, with this slide, and to just get back to reality, because often when we talk about, and you all know this, the people in the room in this Community Connect area, but communities are not just a single thing. As everywhere, communities are often most important in areas where we have no reach, where there's conflict, where there's situation. And these days, we're having even more vulnerable situation, whether it is floods like this in Pakistan, where there is no health system or no healthcare providers that respond. And what we see, it's the communities then that actually step up to help in the health and in any of the response situations. So I wanted to put us in the reality and the touch of the importance of community care providers as a starting point. I think I'm going backwards. That's not the idea. Sorry about that. Okay, so as an introduction, I wanted to put a few points forward about primary health care and really the importance of the care at the lowest level, really at the level where people live, where people work, where people go to various services and to their entertainment, whatever they do, that is where we need to have health. And so WHO has brought out the importance of the Alma Ata Declaration, which describes the primary health care, and that focuses really centers people and community. And I think we want to re-emphasize that. And it's also for TB care to really be at that primary care level. So community engagement is defined as a process of working collaborative with communities to address issues affecting their well-being. And what we look at in community-based activities is not in the formal health facilities. So not in a hospital or not in a clinic. It's in the community-based structures, in schools, in places of worship, or in the homesteads of people. Or it is in areas where people work, or by community health workers or community volunteers. That's what most people do, although I am kind of extending it a little bit to some of the informal providers because they often are part of community work. And they can be supported by non-governmental organizations and or the government. So I'm going to show you, lastly, effective community engagement could facilitate access by bringing services to people and reduce the costs. And so what you see here is some examples. We did a literature review around 30 or 40 examples of community practices. So we didn't do the literature review in a sense of an academic literature review, where we did actually a literature review of practical examples. So organizations, NGOs, their work, what was documented, that's what we try to look at. So what we found is very much in line with the most recent community framework that was launched by WHO, but examples of the community-based activities go beyond the work that we see very often focusing on advocacy or communication. It's very much involved in the health service delivery, more and more. Community, and especially during the pandemic, we've seen that communities have become crucial delivers of medicine, of facilitating services, prevention, awareness raising. All of these aspects have become even more important. And of course, the social support and protection aspect in directly supporting people living with TB. So I'm going to show you some of those. If I figure out how this mouse works, which clearly I'm not. Before I get into the examples, because I honestly think that my colleagues will do a much better job in giving you the details of the different examples, I wanted to put this framework out here. So we know that the government TB program, the blue box, is working at the national, the state, or the district level, or at the local level. That's what we expect as the national TB program, as delivering our services. And often when we talk about people that are affected by TB or people that have survived TB, as a direct link. But in reality, there's lots of other players in between the national TB program. So you have, if I go up from the people that are affected by TB and basically the communities that we work with, these are the people that provide peer support, that do the advocacy, but also facilitate, as I said, they do the facilitating to the services. So that's where the community is, but the community is more. Communities also are part of the service delivery. And they are our informal providers, our drug sellers. Many of those are part of the community. And so I've put the private, based on our research, we realized that the service delivery providers are actually part of the community in very many times. And they are even more so clustered together in organizations when we talk about NGOs. That's where communities are then called civil society. So community is not just one box. It has different elements when you talk about communities and what their roles are. Hoping that makes sense. So if we look at where people seek care, and we know that people actually seek care in the private sector. And what I mean with the private sector, it's often at the community level. It's the pharmacy around the corner, or again, it is the community providers. And so where we provide care through the national TB programs is often in large public hospitals or in health facilities, and not actually in the areas where people seek care. And so there's a large divide between where we provide the care and where people seek the care. So, and if we go a little bit further into the details, what we found is that the less poor people use formal and qualified providers in clinic, but often these are individual providers based in a community. They do a public job during the day, and in the evening they have their private clinic, but they're close by where people live. And then the poorer people, they go to informal and unqualified providers, because often they are really embedded into the community. They're trusted. That's where they know that they can get the services. So that is causing, in the terminology that the TB world uses, the health-seeking care delay, whether it's the delay in getting towards a diagnosis or the diagnostic delay in actually not getting the right response in the test. So this whole delay can actually be crushed or shortened if we would be providing services much more at the community and at the primary healthcare level. So when we went through our examples, we found that there are different provider types. And I showed that in that kind of overview box that you saw, the different providers that are, so there are much larger variety of providers than we thought we had. They're not all doctors. There's religious leaders that are providing TB services. There's traditional healers, volunteers, informal providers, community volunteers, community health workers, informal private providers, peer educators. All of these are actually most often part of the communities, but are also providing TB services. And what we've seen really is that they are involved in different domains within TB. They do prevention, or they do detection, or they do treatment. So they have a very large extent in where the community is involved, much wider than we normally talk about. And as I said, I'm not necessarily going to go into the details. Clearly not figured out the mouse yet, but I want to show you some of the images. So in Nigeria, as you see a few of these pictures here, this is where the traditional leaders are involved. In IRD in Pakistan, there are different engagement, lots of the lady health workers, private healthcare providers, community workers. Then in Tanzania, my colleague Rabia is going to speak about that, and she'll give you the more detailed insight. In India, we have many excellent examples of engagement, and I'm really happy to have Rajendra with us to talk about Chennai. And I'm sorry, I don't know why I'm doing this. So finally, I would like to just touch base on how can we actually measure the work of the engagement of community. And this is from the community framework that WHO has just come out with, where they showcase the core indicators as numbers and percentage of new patients, and the number and percentage of successfully treated new patients with TB. And that kind of allows us to see that we have a reporting trend coming from communities that is really growing. So the way forward, I think what is really good is that we talk more about how far communities are actually also involved in the service delivery, and that we define it better, that we have more evidence-based information so that we can get the information about community engagement into policies as well. And the people-centered care of TB services needs to be really at the places where people live and work and play. Community is a key bridge between the people affected by TB, and scaling up the community engagement in programming needs expanded evidence, as I said. So finally, these resilient community systems, because they only become systems once they're not individual initiatives, but they have been grown together, will be an excellent place also for any service delivery models for rolling out new tools. And I think that is how I want to wrap it up before I hand back to the chair.
Thank you, Petra. We will now hear about the integrated interventions to address TB in the mining community of Tanzania, where peer educators and community health workers were recruited and trained to provide TB care. So over to you, Rabia. Thank you.
Colleagues, good evening, and thank you so much for connecting with us for today's session. I'm Rabia Kaji, and I'll be discussing about TB and the mining communities in Tanzania. So I have no conflict of interest to report on this presentation. And so I work with the organization called the Shidefa Plus, which stands for Service Health and Development for People Living Positively with HIV/AIDS. It's a national NGO which is based in Northwest Tanzania, and that's where our areas of work we cover. So this work was specifically done in 2 regions of Tanzania, as we can see. So we did it in Geita, but also in Shinyanga region, and we targeted the mining communities. So why TB HIV interventions, especially when it comes to the mining communities? So we all know that our country, Tanzania, is still one among of the high burden TB and TB HIV countries. And we are still missing the people. And looking at the WHO data for 2020, we missed almost 50,000 people with TB. And looking at the artisanal small-scale miners, it is estimated that around 4% were bacteriologically only being confirmed. So looking at this, we see that there is need to target this kind of population, especially the mining population. So these ones are among of the key and vulnerable population. And we can see also other key KVPs, or the key and vulnerable population. As we can see, the people living with HIV, the prisoners, people with diabetes. But now, what you contribute to, or what puts them to be at a high risk, it's because currently in Tanzania, the magnitude of TB among the mining communities is not yet known. But looking at the estimated data from the assessment which was done, it's just showing that 89% among the notified cases along the health facilities found within the mining community were from the miners who were notified with TB. And we can also look at the WHO data for Tanzania cases notified during the 2019. So we have high rates of TB cases coming from the regions, as we can see being circled there. So mining are exposed to silica and dust, and they lack knowledge on TB, HIV, and the other health issues, but also their rate of HIV is also high in a way that their work, the way they engage, they are close to they engage in bad behaviors, including interacting with the sexual workers without using any protection, in a way that they lack knowledge. But also they are immigrant in nature, because whenever there is new discoveries of new mining, whenever there is any new discovery, then they tend to move from one place to another in search for the gold. So their employment is also not informal, so it's informal, making them not being settled in one place. So looking at the National Strategic Plan for Tanzania, which we are implementing for the TB, so we are supposed to identify or to do the screening among 3 million populations, although in a population of 600 million. So through that work, we can also see the community health workers. So coming directly to the need for this presentation. So why community? SHIDEFA did this by engaging the community health workers through the peer mode. So we did engage community health workers from the mining community who provided TB health education, TB screening, and referral services. And those were the areas where they did reach. So they went to the brothels, the stone clashing, the moonlight information sessions were also used. So looking at the work which was supported by the community health workers who came directly from that group where miners came, so we can look at the KVP data, but specifically here I'm interested in the mining because this is the core area. So both indicators, we can see at the cascade from screening to TB notification. So at least among cases which were notified by the project, which were 3,009, so we had a yielding of 16% among miners who were tested for TB. So we can see without the community health workers work, then we wouldn't have achieved such kind of notification. Also looking at the HIV testing, so among the symptomatic people who were linked for TB testing, so at least 18.5% were tested for HIV, and the 552 were notified to have HIV and then initiated on ALT, but the co-infection was 154. So what now others can learn? We understand that TB control in the mining can be achieved, but if at all we are using approaches which are context specific, targeted like the way SHIDEFA did, in including the community health workers who work directly with the mining population. But again, mobile population also requires innovative approaches in order to successfully reach them. That's like the way we did. So innovative approaches included like using the moonlight session, where informat session were put there and reaching them during the night time, because that was the only time where we can meet also them day and night time. But also collaboration with other learning we noted as a key, in a way that Tanzania is also one among of the SADC countries. So we have the teams program. So we could learn and share experiences, and through that we were able to get more insight on how we can keep on reaching the miners and whenever they move to other places. So we need to strengthen system because it's a fundamental in reaching the miners and other KVPs, but also coming to the multi-sectoral, or we call it short-term FTB. It's also important because working with the mine pits owners was really important in linking and giving us time to screen the mining population. It's also important, but also supportive policies. We know most of the KVPs, including miners, some of the policies does not support them, including my country. So there are some issues when it comes to that. So it's very important to also look at this so as to reach. So in my conclusion, community health workers, they are game changers. They are integral part in unlocking the full potential when it comes to primary health care provision, and thus there is need to engage them. So I can go through these ones in a deeply, in a way that these ones are responsible. They can do anything, they can change, they can mobilize the community and providing contact investigation, laws to follow up, and etc. And because they are trusted by the community. So let's stand together and support the community health workers towards providing the primary health care providers, primary health care services. Thank you so much. Yeah.
Thank you so much. I think the value of community health workers should actually be in every talk, because it's if we're talking about point of care, that's who they are. It would actually be great to have them at the union conference to hear from them. We have a video now from Michael Macharia about the Kamesha TB program in Kenya. So he's not here in person, but you can follow on the screen.
Slowly going through Rabia's last slides with the readings. And now, just to let you know that Michael was supposed to be here, but he did not get a visa to enter France. So we're sad that we have to listen to his recording. But I think that is just a sign of travel these days internationally.
I'm making this presentation on behalf of Kenya Conference of Catholic Bishop, USID funded the Commission TB program. I have no conflict of interest to this report. Kenya Conference of Catholic Bishop, USID funded Commission TB program is a 5-year funded program through a cooperative agreement between USID and Kenya Conference of Catholic Bishops. The program started implementation in October of 2019 and runs until September of 2024. Currently, the program in its year 5 of implementation, which is its final year. The program implementation is anchored on co-creation with the National TB program and supported counties that fosters a shared in implementation. In terms of the program goal, the goal of the program is to improve case finding, as well as treatment outcomes for clients seeking care in faith-based and private facilities. In terms of coverage, the program implementation is in 9 counties of Western Kenya, which are TB HIV burdened counties. In those counties, the program supports 140 health facilities, of which 84 are faith-based facilities and 54 private facilities and 2 are public facilities. The program works with affiliated faith institutions such as churches, mosques, schools, and colleges, and also has a community engagement arm through community health volunteers. The program uses a hybrid sort of implementation model, and this model looks at facility level support, working through facility healthcare teams, as well as TB ACF committees support, capacity building and joint through mentorship and joint support supervision for healthcare workers, as well as health facility level data review support. At the community level, the program utilizes community health volunteers for community TB case finding and contact management, community TB outreach services, and it also utilizes religious platforms for TB advocacy and media advocacy. Also uses media advocacy through local and religious platforms. For TB public-private mixed model support, the program supports TB workplace model as well as chemist and community pharmacies, private clinics, and faith-based institutions of learning, as well as supporting sample networking to testing gene expert and TrueNut hubs. At the national level, the program works closely with the National TB Program through co-creation of implementation plans, as well as participation in policy and guidelines and development, as well as participation in TB committees of experts and supporting the TB annual performance reviews. So through the health facility engagement, the program has been able to reach over 3,000 healthcare workers. That is 3,461 healthcare workers through trainings that are lasting at least a day to 5 days. And through continuous medical education for healthcare workers has been able to reach 3,236 healthcare workers. And through on-job trainings, those are one-on-one engagement with various healthcare workers, has been able to uh, do that with 257 healthcare workers. In terms of community level engagement, the program has been able to reach 804 church leaders, 202 Muslim leaders, 420 school heads, as well as 137 teachers and 337 community health volunteers. Over time, in the last 4 years of implementation, the average screening across these supported health facilities averages 90%. In terms of the number of persons that have been able to be diagnosed with TB, the program has been able to reach over 11,172 clients who have TB and has been able to put all those clients ensure all those clients have been put on treatment. And of these 11,000, 4,904 have been bacteriologically confirmed. And then the program has an average cure rate of 84%, an average treatment success rate of 90%. And in terms of public-private mix contributions, in terms of TB case identification of persons living with TB, the program has been able to contribute 66% of county TB case identification. So, in terms of lessons learned over time, one of the things that we realize is that involving religious leaders in advocacy and is a cost-effective and a sustainable way to educate communities for TB. Collaboration with county health departments aligns interventions with local priorities and optimizes program efficiencies. And on the other hand, leveraging on existing community systems creates efficiencies in TB service delivery. When you're looking at engagement of healthcare workers, when you have this frequent engagement, it actually optimizes quality of care and sustains a intensified TB case finding. And working closely with health facility administrators enhances ownership and also improves program performance over time. Then working closely with the TB Link assistance should be a results-driven affair to ensure cost effectiveness of services. And this TB Link assistance, what their role have been is to ensure that all those clients who have been identified to having TB or are presumed to have TB are actually linked to the relevant services within the health facility and from the community to the health facility itself. Then, in terms of joint planning and implementation, when you do this closely with the implementing partners at the regional level, that is at the county level, it ensures efficiency in terms of resources and coverage by eliminating duplication. Working closely with community health volunteers they do a marvelous job and contribute impactfully in terms of TB service support. But one of the things that we've realized is that this is actually a resource intensive because most of their work is voluntary. So we are trying to leverage with the county government to ensure at least the county governments are able to support this one. And at least one of the things that we've seen is that through the Universal Health Coverage Program, the national government has pushed county governments to actually be able to engage community health volunteers, currently called community health promoters, in terms of this. Um, Engagement of members of TB affected communities as champions actually is a wonderful thing because it improves on treatment outcomes and also works to reduce stigma and discrimination. Then, in terms of TB outreaches in the communities, they should be data driven to ensure that you're able to of inefficiencies and ensure better outcomes in terms of identifying persons living with TB. Then TB public-private mix models support is time and labor intensive and requires regular tracking and support mechanisms to just ensure that the members that you're engaging are able to do this, to deliver the services as desired. And once ensuring that this also works is also the fact that you also have to invest on business sense to add value and sustainability to some of the PPM models, such as chemist and private clinics, like linking them up to digital chest X-ray, as well as sample networking them to gene expert testing labs. So this, as I wind my presentation, we are looking at religious leader engagement. That's a pictorial of some of the engagements that we had with religious leaders. Um, these are engagement with members of media in terms of sensitizing them on TB so that they can be effectively report on TB. And this one is for us putting TB in the news through the commercial TB program officers and the entire team, both locally and as well as internationally. At the community level, we do the community level data review with our community health volunteers. And at the health facility level, you're looking at through mentorship and support supervision with county teams as well. I'd like to acknowledge all the counties that we've worked with and the TB PPM, as well as the National TB Program, USID, the Ministry of Health, and the Commercial TB Kenya Conference of Catholic Bishops. Thank you, Mercy.
Right, I think the lessons learned are quite relevant for different projects, and I'm glad that he focused on that. Sorry that he isn't here to answer questions, but maybe also if you have something to ask, you can email him or ask Petra for his details. Yeah, we're looking forward now to hearing from you, Rajeswaran Tiasagesan, about community workers as TB friends in India, in Chennai, India. Thank you.
Good evening, all. My name is Rajeswaran. I represent REACH India. So this session was supposed to be taken by Dr. Ramya, so I'm here as a proxy. But I'll try to answer the best possible to the questions if there are any. So I declare there is no conflict of interest. This model is like community workers as TB friends. We call them as TB Nanbans. Nanban in Tamil language means friend. So TB friends in Chennai, India. So this is a model in Chennai for private sector engagement for TB care and control. So just to give the landscape of the public and private sector in Chennai for the TB program, the Chennai is divided into 36 tuberculosis units, which is again catered by 171 TB centers, 3 medical colleges and 1 DRTB center. So we wanted to mimic a similar model in the private sector to cater the needs of people seeking care in the private sectors. So just to give a snapshot of the magnitude of private sector in the Chennai district. So there are 259 multi-clinics with 40 major hospitals and over 10,000 individual clinical practitioners, 4,000 pharmacies, and a minimum of 1,000 private laboratories. So this is the magnitude of private sector in Chennai. And if we see, like, as we all know, the private sector is the first point of contact to people with symptoms of TB. So we focused exclusively on the private sector engagement for holistic TB care and control. So TB Nanbans or TB Friends, so they are basically community health workers placed at the clinics called as Nakshatra centers. So Nakshatra center is nothing but a hub and spoke model wherein a free space is provided by the private corporate hospitals exclusively for TB program in the private sector. So we have placed our field staff at those Nakshatra centers to provide TB care and control services. So not only the referrals from the particular hospital, but all the individual clinics and also the other multi-specialty hospitals in and around those Nakshatra centers refer their people with symptoms of TB or people with TB for TB care from the reach. So basically these are some snapshots about the training programs, review meetings and supportive supervisory visits to the Nakshatra Center model. The TB Nanbans are basically a group of people who have at least a minimum education qualification of standard 12. So 12th is like a higher secondary in schooling grade in India. And they undergo a comprehensive 3 to 5 day training program on the basics of TB, treatment guidelines, diagnosis, patient care and support, counseling sessions, TPT, etc. So as and when there is a rollout on the addition in the national TB program, such as recently we launched the nationwide TB preventive therapy program. So there will be a training on the TPT for the TB Nanbans. If there are any upgrade, like there is a shift from 6H regiment to 3RH regiment, they'll be trained again on that. So in a calendar year, they would undergo a minimum of 3 to 5 trainings on the current updates of TB to make sure they are updated on their profession. This is the clumsy ball that you see. So that's how the entire network works. So to get the desired outcome in the private sector. So with Nakshatra Center at the point as a standalone project, all those referrals like private practitioners, private hospitals, labs, the community, pharmacies, private labs, people with TB, everything goes and around the Nakshatra Center and the TB Nanban. Because TB Nanbans at the Nakshatra centers provide a single window system for TB care and control. So whenever a person with TB symptoms is referred, so from the time of diagnosis till their treatment completion, including the notification to the NTP program, is done by the TB Nanbans. So what they do in and day out is like facilitate the quality diagnosis. We offer free NAT testing and free digital X-ray testing. Quality assured TB drugs through the NTP program. Comprehensive counseling on tuberculosis, contact screening, initiation on TPT, regular house visits for treatment adherence, facilitation for DBT, which is the Nikshay Poshan Yojana scheme, wherein the government of India is giving about 500 rupees, which is $7 to $8 a month to compensate the nutrition needs of a person with TB. And they also visit the PP's clinic routinely to give the update and feedback about their referrals. So this is the care cascade flow from the time of referral till the treatment completion that is done by the TB Nanbans. Like once a person with symptom is referred to the Nakshatra Center, they are offered NAT or chest X-ray or whatever the desired test from the private practitioner. And also, using TB as an entry point, we offer free screening for diabetes and hypertension also to people with symptoms of TB, people with TB, and also contacts of people with TB. The criteria is age should be 30 and above to get the screening of diabetes and hypertension. And then after the diagnosis, treatment initiation, contact tracing, initiation on TPT, the follow-up done is till treatment completion. In addition, we also do the post-treatment follow-up up to 24 months as a mandate by the NDP program for all those who are successfully completing the TB treatment. So the key results over the last 5 to 6 years of implementation through the TB Nanbans, who play a pivotal role in this Nakshatra Center model, we have catered close to 53,000 people with TB symptoms in the private sector, offered close to 19,000 free chest X-rays and 33,000 free NAT testing, And we were able to diagnose close to 18,600 people with TB, which is one third of the referrals. And also the bacteriological confirmation among people with pulmonary TB is 75%, which is higher among the other models in India for private sector engagement. Similar models are being deployed in Mumbai, Mehsana, and Patna. Their back positive among people with pulmonary TB is close to like 25 to 30 percentage, and in our model it's 70 to 75 percentage. And we were able to notify 21,400 notifications to the NTP program with a treatment success rate of 90%. And over 1,300 private practitioners are actively engaged in the referral mechanism in the project. So the contributions by the TB Nanbans, as I mentioned earlier, they act as a single point of contact to provide holistic TB care and control in the private sector. The active engagement and the feedback mechanism with the PPs was a hit because they were not aware about what happens to the referral if they refer to the program, whether they were diagnosed, whether they were initiated on treatment. The updates were not provided to the private practitioner. But in our model, we closed that loop wherein a feedback is provided promptly by the TB Nanbans. And even during the COVID time, the feedback mechanism was done through WhatsApp with the private practitioners. Like they set up a video call with the patients, they connect because the people with TB may not be that tech savvy, but our TB Nanban played that intermediate role. They connected with the private practitioners, ensured they converted from IP to CP, and also complete their treatment on time. And providing a family-centered holistic care, we get consent to do house visit, and if a person is not willing to do any house visit, we don't force them. But we ask their family members to mobilize to the health facility to do contact tracing and also the counseling sessions. So minimizing dropouts and improving treatment outcomes. So initially when we deployed the PPM model, like REACH is implementing since 1998, over 25 years. So from 70 to 75% of treatment, now we are close to 90% in the treatment success rate among people catered by our TB Nanbans. Yeah, thank you.
Thank you. That was, I was just struck about the training the regular training, because often a new policy is released and then there's so much bureaucracy. The health workers know about the policy, but the training happens much later, so that fills a nice implementation gap. I think it's very inspiring, and there's a lot of systems and approaches that can be adopted by our civil society organizations, so thank you. Let's hear from the group if there's any from the audience, any questions. Over to you.
Yes, they are paid. Some of them are TB champions, but not everyone is a TB champion in the model. Yeah. The TB champion model, like we started from 2016, but most of the TB Nanbans are in the field since 1998 to 1999. Yeah.
Come forward and to talk to the presenters, maybe to talk about to discuss some of your project work. Okay, I think then, let's close the session, but please come forward and, you can learn more about the mining project or the different models of care, and continue the discussion. Thank you for attending, and well done to all the presenters.